Hi everybody, welcome to my YouTube channel Dr. Sreenivas Medical Concepts and my FB page Dr. Sreenivas Concepts. This is Dr. Sreenivas, neurologist from Andhra Pradesh, India. I am also the medical author of the book Focused Neurology. Today we are going to talk about a very important topic and a basic topic which will be useful for all students. Medical, dental, physiotherapy, nursing, students belonging to allied medical sciences, the cranial nerves. So we are going to talk about the most basic but very important topic, the cranial nerves. Along with the cranial nerves, I shall mention the rule of 17 and the rule of 4. Cranial nerves. There are 12 pairs of cranial nerves. I'll talk about the salient features, the most important points, the core concepts of these 12 cranial nerves. The first cranial nerve is the olfactory nerve. Second cranial nerve is the optic nerve. Third cranial nerve is the oculomotor nerve. Fourth cranial nerve is the trochlear nerve. Fifth cranial nerve is the trigeminal nerve. Sixth cranial nerve is the abducent nerve. Seventh cranial nerve is the facial nerve. Eighth cranial nerve is the vestibular cochlear nerve. Ninth cranial nerve is the glossopharyngeal nerve. 10th nerve is the vagus nerve. 11th nerve is the accessory nerve. And 12th nerve is the hypoglossal nerve. Right, now we shall dwell into the details and the important concepts of all these 12 cranial nerves. First is the olfactory nerve. It exits through the skull. It exits the skull through cribriform plate. So olfactory nerve exits the skull through the cribriform plate. The functions of the olfactory nerve, olfactory nerve is for smell. So we can test it by giving non-noxious stimulus such as coffee. And it does not serve any reflex. And the comments. The olfactory nerve is one of the common cranial nerves which gets involved in head injury. Post-traumatic anosmia is very common. So whenever the first cranial nerve is affected, we should always inquire into the history of head injury. Head injury is one of the most important and common causes of the first nerve being affected, the olfactory nerve presenting as anosmia. The second important point regarding olfactory nerve is that when the olfactory nerve gets affected and when there is anosmia, it can be a predictor of a neurodegenerative disease like Parkinson's disease. In fact, one of the most common non-motor manifestations of Parkinson's disease is anosmia. Olfactory nerve dysfunction indicates the future neurodegenerative disorder like Parkinson's. So if we can diagnose anosmia at the earliest, we can pick up the Parkinson's disease at the earliest and start treating the Parkinson's disease. In fact, the non-motor manifestations of the olfactory nerve dysfunction like anosmia predates the actual development or the motor manifestations of Parkinson's disease by years. So we can save so much of time and we can start off treatment early and then probably slow down the progress of Parkinson's disease. So the two important concepts of olfactory nerve are: one, it is a nerve frequently getting affected in head injury. Second, it can predate the development of neurodegenerative disease like Parkinson's disease. Right. Now we'll talk about the second cranial nerve, optic nerve. Optic nerve exits the skull through optic canal. And what are the functions of the optic nerve? Basically, it's concerned with vision. Visual acuity, we check it out by Snellen's chart. Color vision, Ishihara chart. Field of vision by confrontation methods. And then fundoscopy. Check out on the fundus. The reflexes. Second nerve is the afferent limb of the pupillary reflex. Any reflex has got two components, one the afferent limb, second the efferent limb. For pupillary light reflex, the afferent limb is the second nerve and the efferent limb is the parasympathetic fibers on the third nerve. So the reflex subserved by the optic nerve is the pupillary light reflex. The afferent limb of the pupillary reflex is on the second nerve. The important comments I would like to make about the second nerve is that optic nerve is actually a part of the central nervous system. It is the extension of the central nervous system. In fact, the second nerve myelination is done by the oligodendrocyte myelination. So it is a part of the central nervous system, and therefore diseases like multiple sclerosis, which causes the demyelination of the central nervous system, affects the optic nerve because it is a part of the central nervous system. It is not a peripheral nervous system, it is a central nervous system. It is the extension of the central nervous system. So in multiple sclerosis, optic nerve is commonly involved, producing optic neuritis. And how do we test it? We test it by relative afferent pupillary defect. So when we generally throw light, the pupil will constrict and then after some time it starts dilating. Imagine the right optic nerve is affected. So when we throw light on the left pupil, both the pupils will constrict. And then when we immediately bring it to the right pupil, now after some time it starts dilating, but when we throw light on the right pupil, instead of constricting, it is still in the phase of dilatation. There is a lag, pupillary lag. It is because the optic nerve is affected and therefore it does not react to light in an efficient manner, which is known as relative afferent pupillary defect, which indicates that the optic nerve is affected in the form of optic neuritis like multiple sclerosis. The second important concept about the optic nerve is the fundus examination. In fact, this is the only part in the entire body, human body, wherein we can observe a cranial nerve directly. So fundus examination, we are observing the second cranial nerve directly. So a fundus can get affected. There could be papilledema, which indicates that there's a raised intracranial pressure because of the space occupying lesion like tumors, or we can find features of diabetic retinopathy or hypertensive retinopathy when we look at the fundus. Right. Now let's talk about the third nerve, oculomotor nerve. Oculomotor exits the skull through superior orbital fissure. It supplies all the muscles, superior rectus. The third nerve nucleus supplies the superior rectus on the opposite side, and therefore when the third nerve nucleus in the midbrain gets affected, not the ipsilateral superior rectus but the contralateral superior rectus gets affected. It also supplies the inferior rectus, medial rectus, inferior oblique, and the levator palpebrae superioris. Both the levator palpebrae superioris are supplied by a central subnucleus of the third nerve in the midbrain, and therefore when there is a midbrain lesion, there is bilateral ptosis, not unilateral, because both the levator palpebrae superioris are supplied by a central subnucleus, and therefore if there is a midbrain lesion, there is bilateral ptosis. Only when the third nerve at the periphery, if it gets affected, there will be unilateral ptosis. But if it's a midbrain lesion, a central lesion, there is bilateral ptosis. All the eye muscles are supplied by the third nerve except two muscles, LR6 and SO4. Lateral rectus is supplied by sixth nerve, superior oblique is supplied by the fourth nerve. Another important concept of the third nerve is the supranuclear pathways. Basically, in neuro-ophthalmology, we have three kinds of eye movement or ocular movement connections. One, the 3, 4, 6 act in unison for all kinds of ocular motors, ocular movements. One, we have the supranuclear connections, that is the connections coming from the brain to these nuclei of the third, fourth, sixth nerve, what we call the supranuclear pathways. Second, the internuclear pathway, where the third, fourth, sixth is connected with the eighth through medial longitudinal fasciculus, which is called as an internuclear pathway. And then finally we have the infranuclear nerve, that is third nerve, fourth nerve, sixth nerve. So supranuclear pathways are basically three types. One, the saccadic pathways. Second is the pursuit pathway. Third is the VOR, vestibular ocular reflex. Saccadic pathway is a quick, fast movement to one side. Suppose a stimulus comes, example, a pen comes to my right side, I immediately look to the right. This is saccadic movement, the fast, quick movement. It originates from the frontal eye fields area number 8, goes to the PPRF on the opposite side, paramedian pontine reticular formation, connects the 6th nerve lateral rectus on one side and the medial rectus through MLF on the opposite side. So when the left frontal eye fields area number 8 is stimulated, eyes move to the right. This is saccadic movement. The second movement is the pursuit eye movement. Imagine a nice shuttlecock match is going on between two star players. I keep following the shuttlecock. These movements are known as pursuit movements. For pursuit movement, the stimulus is a moving object. It comes from the parietal lobe and goes to the PPR, paramedian pontine reticular formation, which is in the pons. So pons is responsible for all kinds of horizontal eye movements, whether it is saccadic or pursuit, and midbrain is responsible for all kinds of vertical eye movements, whether it is up gaze or down gaze. So pursuit movement comes from the parietal lobe on the same side to the PPRF, and the parietal lobe gets affected. Pursuit movement, slow movement to that side gets affected. For example, the parietal lobe abscess is there, the pursuit movement to that side gets affected, and if it's got fever, it's an infective pathology on the parietal lobe, we can diagnose it. Third is the vestibulo-ocular reflex. The vestibular nerve, as I said, 8th nerve is connected to the PPRF on the opposite side. So the third nerve for example, the right vestibular complex gets connected to the PPRF on the left. That is medial rectus on the left, lateral rectus on the left and medial rectus on the right. So when my 8th vestibular complex is stimulated, my eyes will move towards the left side. This is known as vestibulo-ocular reflex. So I can stimulate it either by pouring warm water or by turning my head to the right side. When I turn my head to the right side, the right vestibular complex is stimulated, the PPRF on the opposite side is stimulated, the eyes will move to the opposite side. Lateral rectus, medial rectus, again this is the third nerve. So the third nerve, we have to test all the individual muscles except the S44 and LR6, which is supplied by the 4th nerve and the 6th nerve, and the supranuclear eye movements, the saccadic pathway, pursuit pathway, and the vestibulo-ocular reflex. The third nerve is the efferent limb of the pupillary reflex. The pupillary reflex has got afferent limb and the afferent limb. The second nerve, efferent limb, is the parasympathetic fibers on the third nerve. The important comment I want to make about the third nerve is that on the third nerve, the parasympathetic fibers run superficially. So if there's a compressive lesion of the third nerve like uncal herniation or a posterior communicating artery aneurysm, it will first affect the parasympathetic fibers running on the third nerve. So the pupillary fibers gets affected. So pupillary fibers should be constricted, but since parasympathetic fibers are affected, pupil will be dilated. So one side pupil dilated, the other side pupil normal, anisocoria. It indicates that the parasympathetic fibers of the third nerve on that side are compressed by an extrinsic pathology like uncal herniation or posterior communicating artery aneurysm. But if there's an intrinsic pathology of the third nerve like diabetic third nerve, it affects the center of the third nerve, but it spares the parasympathetic fibers which run superficially. So it will have other features of the third nerve palsy like double vision, divergent squint, and drooping of the eyelid, but pupil is usually spared. That's why diabetic third nerve palsy is sometimes known as pupillary sparing third nerve palsy. So extrinsic lesion, pupil is the first to get constricted, to get affected. Intrinsic lesion, pupil will not get affected. In case it gets affected, it is the last to get affected. Now we'll talk about the 4th nerve, trochlear nerve. It exits the skull through the superior orbital fissure. The 4th nerve supplies the superior oblique on the opposite side. So superior rectus is supplied by the contralateral third nerve. Superior oblique is also supplied by the contralateral 4th nerve. Both the levator palpebrae superioris are supplied by the central third nerve nucleus in the midbrain. Very important concepts. And therefore, when the superior oblique gets affected, it causes intorsion. So person cannot intort. To compensate that, person will intort his head. To compensate for the eye intortion, which is not taking place because of the superior oblique palsy, they intort the head. So this is known as head tilt sign, otherwise known as Belshazzar's sign. So if we see someone coming to the clinic with the head tilt, we should always suspect 4th nerve palsy, trochlear nerve palsy. The fifth nerve, trigeminal nerve. The trigeminal nerve has got three components: first division, second division, and the third division. First division, ophthalmic division of the trigeminal nerve, exits the skull through superior orbital fissure. The second division of the trigeminal nerve, the maxillary division, exits through the foramen rotundum. And the third division of the fifth nerve, the mandibular division, exits through the foramen ovale. So the motor and sensory, how do we test? The motor, we test by opening the jaw, asking the person to open the jaw. Muscles of mastication, we ask him to again close the jaw. We see the hardness of the muscle, the contraction of the muscle, jaw closure, which is done by the masseter. The sensations, the ophthalmic division, maxillary division, and the mandibular division. The ophthalmic division supplies the forehead, the maxillary division supplies the cheek, and the mandibular division supplies the jaw. Again, an important concept here is that herpes zoster ophthalmicus. Herpes zoster affects the first division of the trigeminal nerve, whereas trigeminal neuralgia usually affects the second and third divisions of the trigeminal nerve. Reflexes. Trigeminal nerve, the ophthalmic division of the trigeminal nerve, forms the afferent limb of the corneal reflex. The efferent limb of the corneal reflex is by the seventh cranial nerve, bilateral seventh nerve, but the corneal reflex, the afferent limb, is the trigeminal nerve, the ophthalmic division. What is corneal reflex? When you touch the cornea with a wisp of cotton, example on the right side, both the eyelids close. The afferent limb is the ophthalmic division of the trigeminal nerve, goes to the pons, bilateral seventh nerve, the closure of the orbicularis oculi on both sides. The important concept about the fifth nerve is to differentiate between the pseudobulbar palsy and bulbar palsy. In bulb we have 9, 10, 11, 12 nerves. And if both the cortico-bulbar fibers supplying 9, 10, 11, 12 nerves get affected, they also manifest with features of 9, 10, 11, 12 nerve palsy, and bulbar palsy also will have features of 9, 10, 11, 12 palsy. So how do we differentiate a bulbar palsy where the medulla oblongata per se is involved, or pseudobulbar palsy where the lesion is above the medulla oblongata, perhaps above the pons? The differentiation is by jaw jerk. Jaw jerk, the afferent is the trigeminal nerve, efferent is also the trigeminal nerve. So when we try to elicit the jaw jerk, if the jaw jerk is brisk, that is the deep tendon reflex is brisk, the lesion is above the nucleus, upper motor neuron. So the lesion has to be above the fifth nerve nucleus, that is above the pons. So the jaw jerk is brisk, it is pseudobulbar palsy. If the jaw jerk is not brisk, it is bulbar palsy. So that is a very important concept about the trigeminal nerve and the jaw jerk. Abducent nerve. Abducent nerve exits the skull through the superior orbital fissure. It supplies the lateral rectus. There is no reflex for the sixth nerve, and an important point about the sixth nerve is that it causes the lateral rectus to act for abduction, and therefore if there is a sixth nerve palsy, lateral rectus palsy, they'll have double vision on looking at far off or distant objects. Double vision on looking at far off objects is sixth nerve palsy. Double vision on looking at near objects is the third nerve palsy. Third nerve adduction, sixth nerve is abduction. Seventh nerve, facial nerve. Facial nerve exits the skull to the internal auditory meatus. It exits the skull to the internal auditory meatus. How do we test seventh nerve? By muscles of facial expression. We ask them to raise the eyebrows, frontalis. We ask them to close the eyes, orbicularis oculi. Shut, puff the cheek, show the teeth. These are all the ways we test the seventh cranial nerve. And another function which test of the seventh cranial nerve is the taste sensation of the anterior two-thirds of the tongue. As I said, the reflex subserved by the seventh nerve is the corneal reflex. It forms the efferent limb of the corneal reflex. So when we touch the cornea with the wisp of cotton, ophthalmic division of the trigeminal nerve is stimulated. It goes to the pons. Bilateral seventh nerves are stimulated. They cause orbicularis oculi, closure of the eyelids on both sides. So a very simple way of testing a brainstem reflex is by corneal reflex. And another important point here we would like to make is that, very important, all cranial nerves are bilaterally innervated except seventh cranial nerve. The seventh cranial nerve has got upper part and the lower part. Upper parts has got bilateral innervation like other cranial nerves, but the lower part gets innervation only from the opposite side. And therefore, when there's a supranuclear lesion, for example, if there's a left cortical lesion, the right lower part of the facial nerve nucleus gets affected, the lower part supplies the lower part of the face, and hence the lower part of the face gets affected, and there's hemiplegia on the same side. So in a UMN lesion example on the left side, there's a right hemiplegia and a right lower facial weakness. Whereas if it is an infranuclear lesion, both the upper and the lower parts gets affected, supplying the face on the same side gets affected. So both the upper part and the lower part on the same side gets affected. The infranuclear seventh nerve palsy, classic example is Bell's palsy, or it could be even a Pontine infarct. So supranuclear palsy of the facial nerve causes a lower half facial weakness on the contralateral side, whereas an infranuclear lesion of the seventh nerve affects both the upper part and the lower part of the face on the same side. Vestibular nerve, the eighth cranial nerve, it exits the skull again to the internal auditory meatus. Here it has got two components. One is hearing, second is the vestibular component. Hearing, if there's a mild hearing loss, we can test by whispering or making sounds with the fingers. The other objective way of testing hearing is Rinne's test and Weber's test. These two tests are based on the principle that the air conduction is better than bone conduction. So if there's a conductive loss, if there's a wax or something in the conductive apparatus, bone conduction becomes better than air conduction. Generally, air conduction is better than bone conduction, but in conductive hearing loss, bone conduction becomes better than air conduction. This is Rinne's test. Weber's test, we place the fork on the center, and then it is better heard or localized to the deaf ear if it is a conducting deafness, because if there's a conductive deafness, it can get transmitted through the bone. So we have two tests. One is the Weber's test and second is the Rinne's test, by which we can localize whether it is a conductive deafness or a sensory neuronal hearing loss. Vestibular apparatus. So the Rinne's test, generally the air conduction is better than bone conduction, but in Rinne's test, bone conduction becomes better than air conduction, conductive hearing loss, whereas Weber says it is localized to a deaf ear. The vestibular component of the eighth nerve. Here I would like to make a small, I would like to explain a small concept. The vestibular apparatus has got a tendency to push everything to the opposite side. If the vestibular complex is stimulated, example on the right side, it pushes the eyes to the opposite side. It pushes the shoulder, it pushes the entire body to the opposite side. That is the normal functional response of the vestibular complex to the stimulation. So when the vestibular complex gets stimulated, the eyes will move towards the opposite side, and the nystagmus will be to the same side, because the frontal eye fields area number 8 will try to correct the eyes and put it back to its normalcy. So when you put warm water, you are stimulating the eyes, it will move to the opposite side. Example, on the right side, it will move to the left side. So frontal eye fields will push back the eyes towards the same side, that is the right side. So there will be nystagmus. We call it by the acronym COWS, cold opposite warm side. So if you put warm water, the nystagmus will be towards the same side. That is one. Second thing, we ask them to fixate on the pen and immediately turn the head to the opposite side looking at the pen. If the vestibular complex is normal, even if I turn my head to the right side, I can turn immediately my eyes to the left side, I can fixate it, because the vestibular apparatus gets stimulated. In persons who got vestibular apparatus dysfunction, when they turn the head, the eyes also will move along the head, and they have to make a corrective saccade like this. So this we make use of in head impulse test in terms of finding out whether it is a central vertigo or a peripheral vertigo, head impulse test in vertiginous patients. Star walk. As I said, when the vestibular complex is effective, it is stimulated, it pushes the body towards the opposite side. So when the vestibular complex gets affected, dysfunctional, the body will move towards the same side. So when they are asked to walk, they tend to move towards the same side as that of the lesion. So when they are asked to rotate around the chair, they make wider and wider circles. They keep moving away from the object. Star walking. They cannot walk on the straight line. They keep moving in other directions because they are pulled towards the side of the lesion. There is no reflex. Right. In comatose patient, we test the vestibular-ocular reflex. So when we test the vestibular-ocular reflex or oculocephalic reflex or doll's eye movement, when we turn the head to one side, the eye should move towards the opposite side. If the vestibular-ocular reflex is intact, that means the brainstem is intact. That means the third, fourth, sixth nerves are functioning well. It rules out an infranuclear pathology. The ninth nerve is the glossopharyngeal nerve. It exits the skull through the jugular foramen. The glossopharyngeal nerve, it supplies the sensation over the pharynx and the palate. It also gives the taste sensation over the posterior one-third of the tongue. The reflex observed by the ninth nerve is the gag reflex. It forms the afferent limb of the gag reflex. When the ninth nerve gets affected, the taste sensation over the posterior one-third of the tongue is lost. 10th nerve is the vagus nerve. It exits the skull through the jugular foramen. It supplies the muscles of the palate, so movements of the palate has to be tested, and then it also gives parasympathetic supply to the viscera. The reflex observed by the 10th nerve is the efferent limb of the gag reflex. When the 10th nerve gets affected, patient may have hoarseness of voice, nasal twang, nasal regurgitation, and dysphagia. These are the classic 4 symptoms we should ask in a person who is supposed to be suffering from the 10th nerve lesion. Hoarseness of voice, nasal twang, nasal regurgitation, and dysphagia. The 11th cranial nerve is the accessory nerve. It exits the skull through the jugular foramen. It supplies 2 muscles. One, the sternocleidomastoid. The sternocleidomastoid will turn the head to the opposite side. And second is the trapezius, which is responsible for shrugging of the shoulder. An important concept of the 11th cranial nerve is that when I was talking about the 7th cranial nerve, I said all the cranial nerves have got bilateral innervation, but the 7th nerve, the lower part, has got contralateral innervation. Unlike the other cranial nerves or 7th cranial nerve, the 11th cranial nerve nucleus has got predominantly ipsilateral innervation. So when the right cortex gets affected, it is the right sternocleidomastoid, not the left. It is the right sternocleidomastoid which gets affected. Sternocleidomastoid turns the head to the opposite side. So when the right sternocleidomastoid gets affected, it cannot turn the head to the left side. The other sternocleidomastoid will override and will push the eye head to the same side. So in the right cortical lesion, there will be left-sided hemiplegia, but the head will be turned to the same side of the lesion. So the supranuclear supply of the 11th cranial nerve nucleus is predominantly ipsilateral, a very important concept. The 12th cranial nerve is the hypoglossal nerve. It exits the skull to the hypoglossal foramen. It is responsible for all the tongue movements. The genioglossus pushes the tongue towards the opposite side, and therefore when the 12th nerve gets affected, the genioglossus cannot push the tongue towards the opposite side. Tongue will move towards the same side of the lesion. So this is an overview of all the cranial nerves, the 12 cranial nerves. Now I'm going to talk about 2 important rules which will help us in understanding the cranial nerves better. One is the rule of 17, second is the rule of 4. According to the rule of 17, 10 plus 7 is 17, 12 plus 5 is 17. The 10th nerve and 7th nerve, if they are affected, the movement will be towards the healthier side. For example, if 7th nerve and 10th nerve gets affected, on the right side, the movement will be towards the left side. 12 plus 5 is also 17. So if 12th nerve and 5th nerve gets affected, their function is to push movements towards the opposite side, to move parts to the opposite side. So when they get affected, the movements will be towards the same side. So if 10th nerve and 7th nerve are affected, the movement will be towards the healthier side. If 12th nerve and 5th nerve gets affected, the movement will be towards the diseased side. This is rule of 17. Second is the rule of 4. According to the rule of 4, there are 4 cranial nerves, and in each part of the brainstem, we have midbrain, pons, medulla oblongata. There are 4 cranial nerves in midbrain and above. That is first, second, third, and fourth. Third and fourth are in the midbrain, and first and second are above midbrain. We have another 4 cranial nerves in pons, 5, 6, 7, 8. Another 4 cranial nerves in medulla oblongata, 9, 10, 11, 12. So there are 4 cranial nerves in each part of the brainstem. 9, 10, 11, 12 in the medulla oblongata, 5, 6, 7, 8 in the pons, 3 and 4 in midbrain, 1 and 2 above midbrain. And according to the rule of 4, as it continues, it says we can localize the cranial nerves whether they are placed medially or laterally. The cranial nerves which divide 12 into equal parts are placed medially. The cranial nerves which divide 12 into unequal parts are placed laterally. For example, we'll see from 3 to 12. The third nerve in the midbrain, 12 by 3 is 4 equal parts. 12 by 4 is 3 equal parts. So third and fourth are placed in the middle of the midbrain. We have 5, 6, 7, 8 in the pons. 12 by 5 is not equal parts. It is unequal parts. 12 by 6 is 2 equal parts. So sixth cranial nerve is placed medially. 12 by 7 is unequal. 12 by 8 is unequal. So in the pons, only sixth nerve is placed in the central part, whereas 5, 7 and 8 are placed laterally or sideways. Next, medulla oblongata, 9, 10, 11, 12. 12 by 9 is unequal, 12 by 10 is unequal, 12 by 11 is unequal part. But 12 by 12 is an equal one part. So the 12th cranial nerve is placed medially, but 9, 10 and 11 are placed laterally. So the cranial nerves which divide 12 into equal parts are placed medially, like 3 and 4 in the midbrain, 6th in the pons and 12th in the medulla oblongata. The cranial nerves which do not divide 12 into equal parts are placed laterally, that is 5, 7 and 8 in the pons which is placed laterally, 9, 10 and 11 in the medulla oblongata which is placed laterally. So this is the overview of the cranial nerves and overview of the rule of 17 and overview of rule of 4. I hope you have enjoyed listening to my lecture. If you have any suggestions or comments, kindly post on to my YouTube channel. But please like and subscribe my YouTube channel, Dr. Sreenivas Medical Concepts, and my FB page, Dr. Sreenivas Concepts. Thank you. Bye.